So we're just into the last session for the day, and our next speaker is Dr. Tony Badrick, who we've introduced earlier. So welcome, Tony.
Thank you. I know we're late, so let's try and see how fast I can go through this. The presentations will be available. We're going around asking all the speakers now if they'll give us permission to post them so that the presentations will be available. You'll get a message soon as to how to access them. So they will be available. As well, the video will be available too. So that should help. So I'm going to talk about EQA and interpreting EQA. And there's two key concepts I want to get across to you. You've probably heard them, but I'm going to emphasise what they actually mean today. So one's traceability, metrological traceability. So metrological traceability is a property of a measurement where you're measuring something here, you're measuring... Slides aren't on yet. Oh, sorry. Something always goes wrong.
There we go. Those two are on.
So sorry about that. The technology has let us down. So I'm going to talk about two key concepts. If you look on the outer screens, not the inner screen. So the first one is traceability, metrological traceability, and what it basically means that if you're measuring something that you can trace back from that something, the measurement, the system that you're using, the method, the reagent, you can trace back to a calibrator that was perhaps made in the factory, and then the factory can trace back from however they determined using that calibrator, the calibrator value, trace back further to where they got the calibrator material from, to where a reference laboratory may have put a value on that calibration material using a particular method, perhaps going all the way back up to some sort of National Measurement Institute, which is determined a reference value for a certified reference material. Okay, so there's this unbroken chain of reference methods and certified reference materials. So you know that what you're measuring is traceable back to a pure standard using a very high definitive method. The other concept is commutability. And commutability means that the reference material, be it a calibrator, QC or EQA material, behaves in the same way that patient samples do. And we've talked about this a whole lot of times today. But I think now, as a community of scientists, we're starting to realise just how important these concepts are and how impactful they can be on patient results. So I think we've all seen this diagram lots of times, which basically says that nearly all the problems that we have with our results are related to either pre-analytical or post-analytical error, and that really within the lab, our results are really, really good. Yep, wrong. So I don't think that's true. I think we've deluded ourselves that we're putting out high-quality results. Okay, I know we can't control them, and we've always relied on the manufacturer producing really great analyzers and all that sort of stuff, but we also rely on them producing really high-quality calibration material. Right? We rely on them, the analyzer being good, and the calibrator that they give us. And if the calibrator value is 123, we assume that that's correct. The manufacturer said it was 123, so therefore it's 123. Right? Wrong. Okay, so let's talk about that. So what are the requirements of EQA? Well, really, in terms of EQA programs, it's really to identify laboratories that are high risk if you're a regulator. If you're a laboratory, you want to identify methods that are not very good. So we want to identify is the lab performing as well as the method allows them to. And we also, across different methods, we want to characterise bias and imprecision. That's what we don't do very well. Or if we do it, we ignore it. Okay? We think that if our method has got a bias compared with another method, that's okay. As long as I'm doing as well as my method, we think that's okay. That's all right. I'm doing as well as the worst method can allow me to perform. That's okay. That's what you do, isn't it? You compare yourself against your method peers. And so as long as you're performing well with your method peers, that's all right, isn't it? So if you're with a bunch of bad drivers zooming down the highway at 300 kilometres an hour, because we're all together, that's okay. Is there any risk in that? Okay. So there's an issue about reference value assignment. If your EQA, is your EQA providing you with values for the material that are actually at a level of a traceable standard? Can your EQA provide you with a number for what the target value is that's as high as you can get in terms of meteorological traceability? This will become clearer soon. And traceability, there's a whole lot of aspects to traceability, but perhaps the key part of traceability, as far as we're concerned, is an EQA scheme. So certainly you need certified reference materials and a reference method and a reference laboratory and perhaps universal reference intervals, but you also need an EQA to show how you're performing against other people measuring the same measurand in patient samples. Because ultimately what all this is about, what traceability and commutability is all about, is that if you're a patient, here I am, and I go to a number of different laboratories and have the same measurand measured, I should get the same result. So it doesn't matter where I go, if I want something measured, I'm going to get the same result in every lab. Okay? That seems pretty basic, doesn't it? Does that happen? Does that happen now? If the patient goes to a whole lot of different labs, will they get the same result if on the test that's requested? Does that happen? No. Does it matter? Yes. Okay, so this is the traceability chain. So there's a primary reference material and a primary reference method up the top there in one lab somewhere in the world. And then there's this unbroken chain of calibrators and measurement systems to ensure that there's consistency between the patient result and this certified reference material. Sounds great. We've got a bit of a problem in that a lot of what we measure, a lot of the measurands that we measure, a lot of the hormones, a lot of the antibodies that we measure, we don't actually know what the structure is. And we don't actually have a pure standard because we don't actually know what the structure is. You know, a lot of the peptide hormones, they've got lots of carbohydrates attached to them, and sometimes the carbohydrates vary in health and disease. So in fact, it's really hard to work out. We can't come up with a reference method. And it's also very hard to measure some of these hormones. You know, we're starting to measure them now by mass spec, but up till now we've used methods like antibodies, antibody methods, immunoassay, and you know that they're fraught with problems. So this is from the JCTLM database, which is the database which has all the reference methods that are known and all the certified reference materials that are known. And you can see that whilst there's 290 materials, we measure a lot more things than that in laboratories, and some of those are duplicated. So we have a problem with traceability in that for a lot of the things that we measure, there is no traceability change, because there is no reference method. There is no reference material. Okay. So now let's talk about us. We're in a laboratory. So as part of the customers of an EQA, what do we expect? Well, what we want to know is my laboratory following the manufacturer's guidelines for my method? Am I getting the same results as everybody else using this method? That's what we do, isn't it? Realistically, that's what we do. So we might look for linearity and quality improvement and interference as part of that, but fundamentally we want to get the same results as our peers. An accrediting agency who is insisting that we meet the requirements of 15189, providing that we're in EQA, providing that we respond to any non-conformances, they're probably happy too. Okay? Is there any risk in this? Risk to patients? We get the same as everybody else using our method. The accrediting agency said, yep, you're doing the same as everybody else. What can be wrong with that? What we in fact do when there's not a full traceability chain, we have this minor traceability chain where we can trace our cells back to the manufacturer of our assay or kit. Okay? So we have a limited traceability, but everybody using our method should get the same result. Okay? Because we're relying on the manufacturer of that kit to ensure that they've got stability in the calibrator values. Okay? So as long as I get the same answer as my peers, I'm right. Okay? So you will have seen something like this. This is a ferritin EQA from our EQA, our old system. And when you look at the results, for this lab, they performed well with one sample and they're sort of on the borderline of the APS on the other sample. When you look at the results, you can see that there's a bimodal distribution. You can see that there's a whole lot of values that are outside the APS on the lower end and some that are outside the APS on the upper end. And you can see that this is me, and as far as I'm concerned, I'm doing well. I'm getting the same result as my peers, so that's good. But you can see there's another population that's at the other end, and that peer group are also doing well. They're quite tight, but they've got a completely different answer. And you can sort of see there the two populations. So for ferritin, two completely different populations of results. They're actually quite tight, so the different methods are getting the same answer as each other, but they're getting two different answers on the one sample. So people would say, oh, it's a problem with the EQA material. It's an artefact. Okay? This is a liquid serum chemistry program, so this is patient samples. So this is a sample that's come from a patient who's undergone phlebotomy because they've got hemochromatosis. It might have been pooled with that same patient, but as far as we can tell, all we do with the sample is we freeze it, and then we send it out. We have problems because we can't send it very far away, but we do send it within Australia to a whole lot of laboratories. So as far as we're concerned, this is a commutable sample. And if you look at the spread of results down here on this left-hand diagram, you can see that there's an enormous spread of results. And this enormous spread of results is because of those method differences. So those method differences that we see here in the normal EQA material is also present in patient samples. So patients would have this same spread of results depending where they went. Okay? And you'll actually see down here, so it's liquid serum chemistry, you can see the two populations. And you can see here the results on these two samples down there on the right-hand side. And if you look at the Roche method for the low sort of ferritin level, the Roche values go from 37 to 49. The ortho values go from 16 to 24. So they don't even overlap. And you can see there's a big spread of results based on the methods. Okay? So same measure and different method, completely different results. Does it make a difference? Does it make a difference? Iron deficiency. So what's the criteria for iron deficiency? Less than 15, you're iron deficient. So if you had your ferritin measured in a lab that's got sort of a low, first question is, which method did they use to determine that the cutoff was 15? And we don't know. It works the other way too. Iron overload is, there's a cutoff about 150. Same problem there, because the results from these methods are really, particularly the Roche method, is really an outlier compared with the others. So where there's a tight cutoff and you get methodological differences that are real, they really are there, they're not just an artefact, you get misclassification of patients. So if you've got anemia, you've got a low ferritin, maybe you've got a low ferritin by somebody's method. If you have it done in a Roche lab, you're going to get fixed overnight. Just go to a different lab and your anemia will go away. Unfortunately, it works the other way. You might have a Roche method ferritin which is high, go to an ortho method for a ferritin and you become anemic overnight. And this is just more data from a paper which shows the same sort of thing where the cut-offs are, and you can see by the number of dots that depending on the method, if you're an unlucky dotter, you're going to be iron deficient. So it's a problem for ferritin, that's an immunoassay. Is it a problem for other methods? Yes. This is albumin. Depending on whether you measure albumin by immunoturbidimetry or colorimetry, you'll get a different result. So this is from COVID when they were using albumin, serum albumin as a risk factor for patients with COVID. You can see that there's a separation if you use immunoturbidimetry between high-risk patients and not, and there's no differentiation at all if you use colorimetry. So clinically it makes a difference. This is just showing some other sort of similar results. These are, I think Peter talked about these before. You can look at things like, this is for urinary albumin using point-of-care devices, and you can see that if you look at some methods, the CV is really quite low for the individual method, but CVs across all methods is high, and that's because there's bias between the methods. So within a method, you'll see it here for HbA1c. Within a method, the HbA1c CV is actually quite tight. If you look at all methods CV, it's higher, and that's because there's bias between methods. And you can see the extent of the bias here, 4.8 to 5.6, 10.3, 9.6. So there's actual bias between methods. So within your peer group, you're doing really well, but if you're a patient, you could be at risk depending if you look at two different methods. Okay? So we're not as good as we thought we were. This is what commutable samples show us, and this HbA1c material is available in Malaysia. This is glucose, and glucose looks really good. Look at the CVs for glucose, 1.3, but if you look at again, variation between methods. Within a method, the CV is really tight for glucose. Between methods, it's not quite so good. This is the same data that Peter showed earlier. This is again for whole blood HbA1c, and you can see that on these two samples, a low sample and a high sample, with these have got reference method value assignments, that on the low method, the Biorad D100s have got a positive bias, and on the high sample at 10, the ECA values have got a high value. So these are commutable material, and there are real problems with different methods. I'll switch gears now. So one of the things we like to do is have common reference intervals. How can we have common reference intervals? You have common reference intervals if you can show that the results on the same patient samples or a series of patient samples are the same for different methods. Different methods, if I send out some patient samples, I get the same results. If I get the same results, I can use the same reference intervals. So we've done some work using this commutable material to in fact validate. Australia has got common reference intervals for some biochemical analytes. We wanted to verify that in fact that's true. So we wrote a paper a little while ago and we published that just to show that we've done some work to see whether or not you can in fact do that. Can we use common reference intervals? Can we use the reference intervals that we've got based on whether or not with these commutable samples you get the same results on different methods for the same patient? And in fact, that's what we showed, that you can't use commutable reference intervals for ferritin, no surprise, that's what I just said. B12, no surprise, difficult method. Chloride, that's a surprise. Albumin, ALT, free T3, lipase, free T4. And there's poor correlation for LD, ALT without P5P, LD, albumin. So what we've assumed we could do in Australia, based on work we did 10 years ago, that you could use common reference intervals, might not be valid. And that's because what happened 10 years ago may have changed. The manufacturers may have changed their calibration. So once you've defined or you've determined that something works, you have to keep checking it. You have to keep checking the traceability, and you can only do that with EQA. So what we want to do is harmonise reference intervals. We want to harmonise methods, so no matter where you go as a patient, no matter which method is used, you get the same results. That's clearly what we want to do. We don't really do that currently. We're just starting to work out that, in fact, it's a problem. As I said with the ferritins, it's a problem. We thought that it was always, an artefact due to the material with EQA or something or other. It's not. It's a real problem. Patients will get different results on the same measure and that make a difference depending where it's measured. That's a problem. So, and this is just so you might have to put factors in. I hate to say this. You might have to put factors in to ensure that different methods align. Some methods we will never be able to, there's no traceability chain, so we can't have a standard out there that everybody can use. The manufacturers are going to continue to come out with their different results. Can we, in fact, make those two results, in the case of ferritin, can we make the Roche ferritin give the same result as the other methods? And we can if we put a factor in. So when would you use factors? If there's a reagent lot change, you know sometimes we talked about lot-to-lot variation. What happens if you find a lot-to-lot variation? As C. Ping said, you might have to put a factor in. So you need a factor. It might be that you have different methods in ED or another lab and the main lab, and you want to get the same results. There was a case in Victoria just 2 years ago where a patient died because there was an ED troponin method that had different units to the main lab one, and the patient was sent home from ED and came back the next day and died. Or you might have two different methods, as we've said with ferritin, this is with lipase. So there are a whole series of situations where you're getting two different results and it's impacting on patient outcomes. So what you need to do is you need to put a factor in. So there are methods available to work out what those factors are and when to use them. Okay? So there's no point saying we're getting two different results. We've got to correct those two different results, so we will have to put a factor in so that we get the same result no matter where the patient goes. I'll just go through this because I'm getting behind. And there are groups trying to come up with ways to harmonise all our results. That's the next thing. We can't always have traceability because we have no reference standards, but maybe we can work on ways of harmonising our results using factors and EQA. Okay, so what's EQA all about? So EQA I look at these patient samples as patient, we're a patient advocate. They're pretend patients. Just remember that. So if you get a different result, if your peer group gets a different result to another peer group, it's a patient that's going to be affected, a little bottle and their child. So patient safety is not a chore, it's what we're all about. And these bottles are not bottles, they're patient proxies. See them as patients. The only way to identify differences between results that impact patients is by using EQA, or if there's a terrible event involving a patient. So EQA is more than just ticking a box like QC is. EQA is all about trying to find out when patients are going to be affected. It's about risk. So summary, commutability and traceability are key components that we need to understand. EQA can identify, I don't know why I do that, EQA can identify variation, but it does have limitations. It needs to be commutable. Don't just look how you perform, but how your method performs compared with others, because think of it as a patient. Patient goes to two different places, same assay, and they get different results. And if there's a sharp cutoff, they're going to be treated, or not, maybe. Ask the question, is this a real problem? Most likely it is. It is a problem. Consider patient risk wherever it arises. Thank you.
Thank you, Tony. I don't have any questions from the audience yet on Tony's presentation then, but feel free to still put them in. We might have a bit of a window when we're setting up for the panel discussion after this next speaker, where I can cover some of the questions, or between us, we can cover some of the questions we haven't been able to get to yet. So please feel free to put more in. So our next presentation, I'll just click on there. I'll just bring it up for you. Oh, you're there? Oh, thank you.